So, with that, again, welcome to our Harm Reduction Project Echo. Today, we're talking about bridging drug user health and palliative care opportunities for compassionate care. Next slide. Our speaker today is Dr. Dosani, who is a palliative care physician and health justice advocate dedicated to advancing equitable access to healthcare for people experiencing structural vulnerabilities like poverty and homelessness. These efforts include founding and leading the Palliative Education and Care for Homeless program in Toronto, serving as the medical director of Kensington Hospice, a health equity expert advisor. If you're just now joining, please make sure to mute yourself. Thank you. He's also a health equity expert advisor at the Canadian Partnership Against Cancer and as a palliative care physician at St. Michael's Hospital. He shares his passion for palliative care and health equity with learners as an assistant professor at the University of Toronto. As a researcher, he's appointed as an investigator at St. Michael's Li Ka-shing Knowledge Institute with a special interest in health system innovation and advancing access to equity-oriented care for structurally vulnerable populations. As you can see, Dr. Dosani is amazing in so many different ways, like a million hats on top of a million hats. So we're very happy to have him. Okay, Ali, I think you can take the slides down and we'll get started. So as I said, today is going to be a little bit different. We're going to have a fireside chat with Dr. Dosani. And Ali will, hopefully we can pin everybody in the correct way so you can see everybody's beautiful faces. So welcome, Dr. Dosani. Anything to say before we get started?
Yeah, first of all, thank you so much for that warm introduction. Can I say it's been such a pleasure to work with you in the back forth in the lead up to this event and such a cool curriculum and training program you've planned. Such an honor to be here with you all. You do such amazing work. So I'm super pumped and super excited for this fireside chat. I don't know if we have a fire, but we have a chat for sure. Anastasia is the fire, I am the side. How about that?
There we go. And then we're hoping the audience brings the chat as well.
Amazing, amazing. Looking forward to it.
Yeah. So I know I went through your beautiful bio, but please tell us a little bit about yourself, what palliative care is. I know we had that knowledge check, so there are some people who are here to learn, and then just how you got into this field of work.
Yeah, for sure. So yeah, once again, I love that. Both fire. My name is Naheed Dosani. I'm a palliative care physician based in Toronto, Ontario, Canada. I work at St. Mike's, which is an inner city hospital with a strong social justice mission, and I'm the founder of the Peach program, which we'll be talking about, which is a community-based palliative care outreach program for unhoused people living in the city of Toronto. Listen, at its core, palliative care is really about improving quality of life for people with serious illnesses. And I always like to pause there because there's this very common misconception that palliative care is only about the very end of life. In reality, it's actually about supporting much people much earlier. Absolutely managing their symptoms and pain, but also psychosocial and spiritual distress and helping people live for as long as possible. It's about supporting families, navigating complexities of the health system, navigating complex care decisions, not just medically, but socially and emotionally. But for me, the path into this work was not linear. I did not find this work. I feel like this work found me. Early in training, I was doing outreach in primary care, working in shelters on the streets in Toronto, and I started to notice something that was really bothering me, and it stayed with me. People were dying, but they were dying in ways that felt invisible to the social and healthcare systems around them. They were cycling through ERs, often with advanced illness, but lacking the kind of longitudinal, compassionate palliative care that palliative care is meant to provide. And I remember thinking, we have this amazing field, palliative care. It's human rights based, it's compassionate, and it's supporting people, but entire populations, such as people experiencing homelessness, are being left out. That really shaped my career. It led to the creation of the Peach program, which started very humbly. We're still humble, but out the back of my beat up old Honda Civic, we used to drive around the streets one day a week seeing clients. And fast forward to 12 years later, Peach is not only the first program in the world, but the largest mobile palliative care program for structurally vulnerable people in the world. From that, and I know we'll talk about some of this later, I've also had the opportunity to develop a new program at Kensington Hospice, which is Toronto's largest hospice. The program is called Radical Love. where we're really embedding equity in a mainstream hospice. It means rethinking hospice in terms of traditional barriers to access and intentionally designing equity-oriented care, like for people who use drugs, for example. This has also led to some national work, which I'm super excited to talk about. We're hot off the heels of this initiative called Improving Equity and Access to Palliative Care, IEAPC, which was a 5-year initiative funded by Health Canada, where we funded and supported 23 equity-oriented palliative care projects from coast to coast to coast. So my work really sits at the intersection of palliative care, homelessness, and most certainly harm reduction. And what I've learned is that when you do this work and you're able to make the mix work and make it work well, it can inspire compassion, flexibility, and be an innovative commitment to equity, which is why I'm so honored to be here today, that you're interested in all of these intersections for sure. Thanks for that question.
Wow. I did a lot of background research into your work, but just hearing you like talk about it out loud, it's so impressive what you all are able to do and how like quickly you've able to expand this, get a ton of people on board from like the ground level to leadership. That's fantastic. So not necessarily specific to the Peach program, but with your work generally, you said it's the intersection of homelessness and palliative care and harm reduction. So specifically, how does substance use intersect with the populations that you serve?
Yeah, I mean, substance use is a really, really, really big part of what we see. I mean, ultimately, a big proportion of the people we see are people who use drugs on a day-to-day basis. And so, many of those folks are actually facing many significant barriers to care. And so, it behooves us to be working and caring for people through a harm reduction context. In practice, this means, many things, lowering barriers rather than creating them. We accept people as they are, including ongoing substance use. We prioritize dignity, autonomy, and relationship building, even when care feels complex or uncertain. And there actually is a natural alignment to harm reduction, actually. In palliative care, harm reduction does take on a unique dimension. We're not only thinking about preventing overdose or infection, we're also thinking about comfort, suffering, and quality of life at the end of life. It is a bit complex. I mean, in reality, many of the medications we prescribe in palliative care can sometimes be the substances that are being used by people on the street, and herein lies some of the complexity. But we practice through a harm reduction approach in that we support people to use drugs, work with our colleagues and our partners who support harm reduction, but also prescribe controlled substances on top of it. It can be complicated. It can sometimes be challenging in terms of moving systems that were not built for folks. But with a lot of dedication and a lot of support, these kinds of things can be possible. We have really believed that storytelling has been a really powerful tool in this work. A lot of Canadians lack an understanding, a baseline about unhoused people. There's a lot of stigma around unhoused people. And when you layer substance use on top of that, that stigma tends to grow. But when you tell the story of an unhoused person who's done all they could to live the best life they could, and then facing serious illness and substance use on top, we found great compassion flows with that. And so we've like really empowered people with storytelling and narratives as well. Lots more to say about that, but I think at the outset, we definitely support a harm reduction approach. We think it's part and parcel. Like harm reduction is a human rights concept, palliative care is a human rights concept, and then they overlap. And then the how and the mechanics sometimes can be challenging, but we just make it work.
That's awesome. Like your program is definitely like the definition of harm reduction, that radical love, that empathy, that compassion. It's like very present through all of that. So more about the storytelling. Um, how is the storytelling the main way, or what other ways do you get more people brought into this mindset? The front desk staff, administrators, other physicians, and then you said you expanded some of your programs nationally and perhaps even internationally.
Yeah, for sure. I mean, I think one of the things that's really important to talk about um, is like what were the domains that have led to success and spread and scale of a program like this. And that's important because I recognize not everyone in this room will start a Peach program, but you will be involved in spread and scale of innovative, equity-oriented models of care. And so I would say, to think about a few domains. First of all, really evaluating the metrics. That really lead to change. When we started the Peach program, we noted through evaluation and metrics that we tracked rigorously that 64% of clients never went to the hospital or ER, 80% died where they wanted to, and 83% were reconnected to family or friends. More recently, an economic analysis that's about to be published shows that for every $1 that's put into the Peach program, the taxpayer is getting $2.06 back in terms of reduced acute healthcare costs. I know not everyone can have those metrics at the outset in your program, but like what are policymakers thinking about? What metrics will move the needle with the public, with taxpayers, with government, with healthcare policymakers? That's one thing to think about. The second thing is really thinking about how we bring our colleagues in healthcare on side when trying to support stigmatized populations. I think we have to think about how to get them to really come on side with a trauma-informed harm reduction lens. One of the things is to create a culture of psychological safety, teaching people about the elements of trauma-informed care, tone, body language, the words we use say so much about us, and the words we use to talk about our clients, and the words we write in the chart, right, make a really big deal. I think we also have to develop models of care that meet people where they are and show our colleagues that that's really important. One of the reasons that a program like Peach works is because we're mobile. We go wherever. There are no-go zones. We go to the parks, we go to alleyways, we go to encampments. Like many of you in this virtual room, you do that work both literally but also figuratively, meeting people where they're at. And I think with our colleagues showing success, like we talk about Peach in the healthcare community in Ontario, in Canada, that serves as a beacon of hope to say you can do this too, right? And so these are some of the ways you can do it. Just pivoting a little bit, we talked a little bit about storytelling. I'm just going to broaden that out to say that is how we've won the Canadian public over in this issue. We have been able to tell stories that have been broadcasted on our national outlets like the CBC, and even have gone international with the Canadian press at times. Stories of people who are struggling, dealing with serious illnesses, have substance use disorders, but then are so interested in care and connect with care. These clients care about their care. They don't care. A lot of people will tell you they don't care, but as you know, they do care. They're just trying to access care from a system that wasn't designed for them. The last thing I'll say is I think the success of Spread and Scale has been about elevating the work to build capacity for the next generation. We've built partnerships, for example, with the University of Toronto, where every palliative care resident now has to rotate with Peach as a core rotation. And that took a lot of work, a lot of advocacy, a lot of schmoozing, but we got there. And that's a very popular medical education rotation that's uniquely offered in our country. And so people actually travel in to come rotate with us so they could take their learned lessons home. I could go on and on about this one, Anastasia, but those would be four domains I would get into.
That's awesome. Definitely please send me that research article once it's published. I know my team, our partners, and then the audience members would be like so excited to see this research because um, there's definitely gaps in the literature right now when it comes to cost effectiveness and safety and things like that.
Totally.
I love that you talked about the culture of psychological safety, trauma-informed care, radical rapport, and kind of this concept of any positive change, which is really what we try to promote amongst our certain services programs and their participants, where the participants are in charge of their own goals. They set what they want because, like you said, they really do care about their health, even if stigma says otherwise. So I really appreciate you talking about that.
Awesome.
Um, I think I said this in your bio. I don't think I made it very clear, but Dr. Dosani, he's from Canada, so it's not the same as the US, but it's still very similar. But recently in the US, there's been executive orders from the federal level against harm reduction programs, specifically targeting overdose prevention sites or safe consumption sites. But how would you describe the current social and policy climate for harm reduction in Canada? Are there regions where policies or perspectives are more restrictive, and how is that kind of navigated?
Yeah, for sure. And I've been intently watching what's been happening south of the border in your situation, in your jurisdictions. And I want to answer this question with nuance because the reality that is that the situation in Canada is not a uniform one. Listen, at a high level, Canada has historically, some would say, taken a more public health oriented approach to harm reduction as a country, like coast to coast to coast, maybe compared to the United States. We've had supervised consumption sites operating legally in multiple cities. There has been, at least at times, federal and provincial recognition, depending on the province and territory, that harm reduction is an essential part of care and responding to the toxic drug crisis. But that doesn't mean that the environment in Canada has been stable or uncontested. In fact, for those who are interested, a really important example is INSITE in Vancouver, which, from my understanding, is one of the first supervised consumption sites in North America. From the beginning, like when I was in medical school, so like a long time ago, it like 2008 to 2011, it faced significant political opposition, including attacks by our federal government at the time. There was a landmark Supreme Court of Canada decision in 2011 where the Supreme Court ruled that closing the site would violate people's right to life and human rights, and it remains open to this day, but people are still going at it. In Ontario, the province I live in, where Toronto is based, we're seeing similar tensions play out. Under our current premier, Doug Ford's government, there has been policies moves to restrict supervised consumption sites, including a legislation to ban sites within 200 meters of schools and effectively stop all funding for new sites. There's also plans to basically defund existing sites, and people are suffering, and Peach is functioning in the midst of this context. People are dying. So we're actually operating in a space of tension, and this issue has been more polarized than ever before, like it has been for many of you. Yes, Crackdown Podcast is great. It's a Canadian podcast, but covering this issue kind of worldwide. Thanks for mentioning that. And so we're seeing a variability in issues. We're seeing some urban centers where harm reduction is relatively well integrated, but then in other regions where it's restricted, contested, or fragile. I went and spoke on an island off the north coast of BC, like 30-minute flight from Vancouver, and in Cathet, and that community is having a huge hyperpolarized conflict right now between two sides of the community who support and then don't support. And sometimes in a smaller community like that, it can be even more difficult. I think as we talk about these things, we need to think about how we navigate this hyperpolarization. I offer three thoughts in this discussion. The first is we need to ground our work in evidence and outcomes. I know that doesn't always work, but it does give credibility and rigor to what we're talking about. The second is we need to build broad coalitions. That's why I think this event today is so cool, because public health, housing, healthcare as a coalition is stronger than one of these entities trying to make a point, but also with people with lived experience. And then I think the third is we got to adapt to the changing political landscape. I know we all want the 10 out of 10 top funded program, but that's not where the politics land right now. We should strive for that from an advocacy perspective. But how can we integrate harm reduction principles into our existing care? Outreach is harm reduction, low barrier is harm reduction, relationship-based care is harm reduction. And then we need to talk about that as harm reduction to keep it bubbling to the top, right? Yeah, it's a question. Are we willing to keep pushing, even though it's politically difficult? It's interesting, right? We need to keep pushing on harm reduction. So Canada has its own set of issues. It's not a panacea, and that's a bit of the story compared to the United States.
I love that you approach this with so much nuance because like everything can feel like it's falling apart at the seams sometimes, but there is like really good work going on, and here's like the three steps how we can work through this, with this, around this, however we can to do the work. I think that'll resonate with a lot of folks in the audience, especially like just integrating the harm reduction principles into existing care. I think that is like I think that should be step one. I think that should also be taught in medical schools, just because there's so many people building their skills, and that is like such a foundational thing to care.
Absolutely.
Um, yeah. Um, Similar vein, but moving forward, like I said, I did some research into some of your work. You've said that the future of equitable palliative care lies in anti-racism. Could you tell us more what you mean by that and why it matters in palliative care and how this looks in practice?
Yeah, that's a statement I've really come to believe through both the evidence, but also what I've witnessed in my own practice caring for equity deserving populations. If you look at the literature, racial inequities in palliative care is not a hypothetical thing. This is well established. Studies have shown that racialized people, including Black communities in the United States, Canada, have reduced access to palliative care services and often have limited awareness about them. We also know that racialized people are more likely to request and receive more aggressive hospital-based care at the end of life and less access to palliative care, which often translates to more suffering and less goal concordant care. So, also for Indigenous peoples, multiple reviews have shown that systemic barriers to accessing culturally safe palliative care, along with underrepresentation in services and a lack of Indigenous-led models, has led to really huge disparities. So they're real and they're consistent. But beyond the data, I've personally witnessed and experienced this. I've personally cared for Indigenous people in downtown Toronto and people from racialized communities who just fear accessing mainstream healthcare, including palliative care. The fear doesn't come out of nowhere. It comes from real experiences of racism, of discrimination, and harm with healthcare. There's lots of studies, like I said, that show this directly, and that Indigenous peoples and media stories here in Canada have shown that Indigenous peoples are experiencing prejudice, shame, and systemic racism, and you often feel that in clinical encounters. Like I've had people I've cared for hesitate to go to hospital even when they're seriously ill. I've had people who are racialized say that their pain will not be taken seriously. I've had people and their street families say that they're wary of palliative care because they associate it with systems that have not treated them with dignity. So when we talk about access, it's it's not about availability. There's enough available resources for people. It's just not getting to the people who need it most, arguably, right? And so for me, anti-racism, anti-oppressive approaches to care, culturally safe care are essential to address this issue. In practice, I think anti-racism is about being intentional. It's things like collecting data so we can see things we don't see, like inequities. It means designing programs in partnership with communities who are most impacted. And it means creating culturally safe spaces, hiring diverse teams, supporting Indigenous-led and racialized-led, community-led models of care. But basically what it says is like, we can't expect people to trust us. We need to earn their trust. And that's the only time where palliative care, it's a special time in people's lives where they're especially vulnerable. So we especially have to earn their trust. And that's the only time when people will feel safe, respected, and will align with what we have to offer.
Thank you for that. I feel like it's a difficult but necessary thing to quell that fear because, like you said, you want people to trust you, but you have to earn that trust. You have to put the work in. And with, funding, capacity issues, all of that, it's hard to sort through the noise to just care and get the work done, but it's necessary.
Absolutely.
Uh, yeah. So at the very beginning of this talk, you mentioned that palliative care is not just about end of life, it's so much more. It's like the comfort, bring families together, things like that. But because it can involve this stage, this end of life, how do you navigate grief and your own wellness in this work?
Yeah, I mean, like palliative care is deeply meaningful work, but it also means that you're regularly bearing witness to loss, to suffering, to injustice, and to deaths that sometimes feel shaped by systems that have failed people. Many of my colleagues on the Peach team or at Radical Love say, like, we basically just spend our days abutting against system failures all day long. I'm sure many of you will resonate with that. And so palliative care is tough. Caring for equity deserving populations is tough, and we're talking about the overlap. So So you're often grieving not just the person dying, but the circumstances around the conditions that led to their death. So for one of the first things that I've recognized is just really telling people and sharing that we need to just acknowledge that grief is part of the work. It's part and parcel of the work. And not something to suppress or move past quickly, but something to actually make space for. That's a really big deal because I think our health system and the health workers in it are often programmed to not think that way. I'll tell you about a way that we actually do that. I'm going to tell you about our Peach grief circles. Peach grief circles have been an intervention we've offered since the start of the Peach program over a decade now. And basically, what happens is anytime a client dies or there's a tragedy in the community, we descend on that site, either physically or virtually. We form a circle, we light a candle, we hold a minute of silence, and then we cry together, and then we laugh together, and then we tell stories. We remember what it was like to care for the person. We reflect on what it was like to care for the person, and then we think about ways that we can reinvest and renew in each other. It's the 4 Rs. These are really beautiful structured spaces where staff across disciplines, including anybody who interacted with a client, especially like housekeeping staff, front desk staff, care aides, everybody, for example, gets to be together. These spaces are structured spaces for people to grieve and be bereaved. And what we found is that in the homelessness and harm reduction space, because grief is often unrecognized and often unsupported, people are just losing clients, their street families, their community members so frequently. And so grief circles are an intervention to intentionally say, we are not okay, but we are going to be okay because we can support each other in the process of being okay. And what's really been powerful is like it's not just helped people emotionally, but it's strengthened teams. It's created healing amidst the crisis and tsunami of grief that we've been seeing. I think in addition to grief circles, I just work with such incredible people. Like we've built a community of workers like you have in your state, who are grounded in principles and values, and we do this work together. We hold each other up. And then I think another thing is I think it would be really hard for many of us who do this work to like just go do the clinical work and go home and go to sleep, because that would really just be really difficult. So we advocate, some with a small a, some with a capital A. Some of us protest at government buildings. Some of us write op-eds. Some of us go on TV, speak on breakfast television. We do whatever we got to do, get on the radio, and that advocacy, while some might think, okay, that's more work, we have seen that advocacy is actually an antidote to the burnout that often stems from grief. And so we come full circle to say, yes, we're grieving, but we're grieving and we're advocating for the plight of the people we care for to go upstream and address these health inequities, so that we can do better for the people we care for. And never forget the famous quote: "Rest is a revolutionary act." Rest is okay. Rest is good. Rest is great. And grounding yourselves with family movement, stepping away when needed is so important as well. I do not pretend to have this issue mastered. It is in constant evolution, but those are some of the things that like I often think about when thinking about wellness amidst this tsunami of grief that we deal with.
Yes, I hold that quote close to my heart. Rest is a revolutionary act, and I love rest. And I really like that you're not ignoring grief, you're not ignoring that sadness because it is a lot and it needs to be um like you need to attend to it and you're still sitting in it, you're reflecting in it, but you're still doing the work, you're still moving forward with the advocacy and using that to help your case and help improve the care for others. Um, so last question before we open it up to the audience. What is the most important thing you've learned from your work in palliative care?
Yeah, that's a good one to distill it to a thing or a set of things. I'm gonna speak about process here. I think the most important thing I've learned is that how we care matters just as much as what kind of care we provide. The how is as important and sometimes maybe more important than the what. In palliative care, we often focus on symptoms. My colleagues in palliative medicine will often focus on symptoms, medications, clinical decisions, and yeah, those are important, obviously. But what stays with people and what I've remembered shapes their experience most deeply is how they are treated as human beings. Are we making people feel seen? Are we making people feel respected? Do people feel like they're mattered when they're in our health spaces? And what this work has taught me is, especially working with people who've been structurally excluded, is that those questions are not being answered equitably. I've cared for people who've gone their entire lives without being told in different ways that they don't matter. And that then, on top of that, when they're sick, they encounter a health system at their most vulnerable times, and they're reminded of that again. I'm here to say, listen, in that moment, we have a choice. We have a choice. We can either reinforce that experience by being indifferent, having rigid systems that are often siloed and policies that exclude, or we can disrupt it. We can be disruptors. Many of you are disruptors. You all disruptors. That's why you're here. We can create moments of dignity, of connection, of care that I think feel different for people than what they've experienced before. And listen, these gestures don't have to be grand. Sometimes it's simple as like sitting at eye level with someone, listening. The silence is an intentional and beautiful act of justice for many people, and showing up consistently when others have not. Those moments are powerful, and they remind people, sometimes people for the first time in a long time, that they are worthy of care. Too often, our health systems make people prove that they have to be worthy of care to get the care. That's not okay, right? And that's a deep lesson for me. Palliative care is not just about caring for people with serious illnesses at the end of life. It's about affirming people's value at a time when they're so vulnerable, especially when systems have failed to do that. So, if we want to build more equitable systems, I think, and I would encourage us all to ask the question, who is missing in the care models we're deriving, and why are they not there, right? We too often design systems where people have to come to us, and literally and figuratively, how are we designing systems that where we can go to people and connect with people in flexible ways? So yeah, I would focus on process, not just the what, but the how.
That was beautiful. I think that's really shifting paradigms, like you said, the how versus like just what we're doing, because it really does matter. All the points matter, everything that we do matters, but really how we're treating people, how we're doing things intentionally and meaningfully, I think is most important. So I want to open it up to the audience, our subject matters experts as well, and my co-facilitators. If anyone has any questions, and Allie, if you can pull up the Menti is for anonymous questions, so feel free to add anything there or in the chat or raise your hand.
You just start yapping because Dr. Dasani are one of my favorite physicians and like advocates in this work. I got to see you speak at the Street Medicine Institute, and I was like, this is a big dog, and he's amazing. Um, but yeah, you're doing the exact kind of work I want to do. I'm an incoming medical student. I've been doing street medicine for over a decade. I'm a former, well, that's not true. Have lived experience with drug use and like sex work and all of the populations that I care so much about. And I guess my question is about like navigating these political spheres within the education system where like for example in Tennessee we have restrictions around like what can sort of be said by institutions, and we're seeing like gender affirming care be criminalized and like harm reduction and all of this, and like if you have any advice to people coming into this work from the like outreach setting where you can kind of be like a loudmouth into a more professionalized setting where you want to do the same thing, but maybe you have to like chill out a little bit.
Yeah, thank you so much, Bo. I really appreciate the kind words, and I do remember that, and I'm really happy that you called me a big dog. I'm going to tell all my friends about that. I've never been called that before, but let's go. Thank you. I'm honored. So yeah, I really think going back to the political landscape, which is, we're seeing in both our countries this hyper polarized political landscape where it's getting more difficult to even say terms, right? Like gender affirming care. And I'm reflecting on a few things. I think the first is that we need to continue to do the structural policy advocacy, the legal work. This doesn't have to fall on your personal shoulders, but we as a community, our institutions need to continue to push. And I know there's a lot of advocacy happening through the legal system in the United States. Pay attention to the Canadian Medical Association. I'm on the board of directors of the CMA, and there is currently a case and a charter challenge that we are supporting because the government of Alberta has limited and constrained access to gender affirming care. There is actually a Supreme Court challenge that's happening there in that province that the Canadian Medical Association is leading. So, and I know there's lots of great work happening through organizations like ACLU, and there's a lot like you guys have way more, I think, like in that realm. Um, and so I think that has to happen. And so that's the first thing. The second thing is just because these policies are changing, the tone and tenor of discussion has changed, doesn't mean the work has to stop. It might mean we have to change the way we are talking about things for a while. Now, some people are probably like potentially cringing at that. I appreciate that, but this is the setting we're in. This is the context we're in. I don't like it either, right? But it just goes without saying that, like, we had a situation at one of the healthcare organizations I work at where we were trying to put out a newsroom story, and the newsroom story was, wrought with, like, terms like anti-racism and and gender affirming care and a lot of like these kind of buzzwords that are often classified to the left wing. And we got a lot of bad feedback saying this is not going to pick up, this is not going to be good with government, current policymakers don't like institutions talking like this, how can we change this? Well, you take the article and you just talk about outcomes. Indigenous children don't get access to care. Mortality rates are 4 times higher for this population. What I'm saying is you can still do the work and communicate about it, but focus less potentially in this state where we're in this current context we're in. I hope it ends soon or changes. Just talk about outcomes, talk about the raw reality. Most people, most reasonable people across America and Canada would agree that, one population shouldn't be dying at a 4 times higher rate than another. Like most people would agree with that. Use that as your starting point and then move from there. There will be a proportion of people who are already converted. There will be a proportion of people who are potentially convertible, and then there are others who will not be convertible at all. Focus in on that potentially convertible. Start with the kind of facts and data you can start with to get them hooked, and then talk to them. Hey, and on a side note, the outcomes we're seeing here are a result of things like racism and other structural determinants of health, for example. So yeah, it's an uncomfortable environment. I even hate the fact that I'm talking to people and telling them like not to talk about things how we like to talk about them, but that's the political landscape we're in. How are we adapting? Because if we just anchor in to the ground and don't move, we're gonna lose, this communications PR, war, if you don't mind me using that term, probably not the best term. And we're gonna lose the message. We're gonna lose that group who are potentially convertible. I hope that resonates, Bo. It's a complex topic. Yeah, thanks so much for the question. I appreciate it.
Thank you so much, Dr. Dasani.
Thank you. We have Rebecca's hand up.
Yeah, just based on something you just said, because I feel like that is something we definitely are experiencing in like adapting the way we talk about things, which I think is like always been a harm reduction thing. But I feel like how I guess kind of like your suggestion or advice or how you navigate balancing that of like just totally doing away, like for us, it's harm reduction without just totally isolating all the work and amazing stuff that happens around harm reduction and like just completely abandoning it through words as well. You know, like, is there balance in the way of like adapting how we talk about things without leaving or making kind of like making it seem like it's not evidence-based or like we're stopping talking about it, you know, being harmful as well.
Yeah, thanks. That's such a great point. Herein lies the complexity of this adaptation we need to do around communications. And you don't want to be so hyperbolic or extreme that you dilute the work you're doing and the amazing work that has been done, right? Many of us are standing on the shoulders of giants, people before us and models before us who created incredible, innovative, equity-oriented models of care. Yeah, this is a tough one. I'd say one of the things that I would say is that mortality data, death data is really powerful. People just really resonate with like this populate, like, in Canada, unhoused people die. Average life expectancy is 34 to 47 years old. I've been saying that for 12 years straight, from my first TED Talk to now, and it still blows people away, right? Mortality rates are 2.3 to 4 times higher than the average Canadian baseline population. Like, the City of Toronto Department of Public Health does collect homeless death data. And every time that data comes out every year, you bet, like front page, Toronto Star, our newspaper, like it is a big headline. So I think big data that tells a story like death data, sadly, is really, really powerful. The second thing is, and I think it's kind of been said, anesthesia, I think you mentioned it, like, harm reduction lives, Bo, you mentioned it too. Harm reduction lives in many of the things that we do in healthcare. Trying to not silo harm reduction as just being for this extreme fringe issue affecting people who use drugs, right? Using a safety belt in a car, a bike helmet. Like you guys know all the classic, analogies of what harm reduction can look like, and kind of embedding it as more of a term that's more normalized, for whatever reason. Tell me what you think, but in the news discourse or the social media discourse, harm reduction just gets people thinking about people shooting up needles in parks. Like, at least that's how I feel, how my friends talk about it. And I'm like, that's not what harm reduction is. It's so many other things. So maybe we need to move the needle on that. And then back to storytelling. Anastasia and I were talking about that earlier. You probably have some really powerful stories that can really be leveraged through media, comms, social media. There's a really cool street doc out of Victoria, BC, who's like going viral on Instagram. She's just doing all these reels. I don't know if you've seen her. We can send that out as a resource later, Anastasia. Like, just I love how she's like telling these stories and like humanizing the narratives of compassion around her that she sees from the street. We need more of that. Like, so traditional media, social media, kind of like telling the story to humanize these stories. So yeah, I don't have a silver bullet for you. I'm struggling here, Rebecca, to do what you're talking about. So I feel you, but those are just some things we talk about. Yeah, thanks for sharing notes. Just pivoting, if it's okay. I see a question from the chat.
Absolutely.
Yeah, cool. Where did initial funding for the Peach program come from? Yeah. So yeah, the Peach program was originally fostered and founded at an organization called ICHA, ICHA-Toronto.ca. I just put the website in the chat. Inner City Health Associates. And Inner City Health Associates is a large, I'm pretty sure Canada's largest homeless health organization that delivers psychiatric care to the unhoused, primary care, and then palliative care through the Peach program. It originally started as an alternative payment plan for physicians, specifically working in homeless healthcare like 25 years ago, and it's evolved into this larger organization now that's delivering homeless healthcare. Fast forward to 2026, the Peach program actually functions as a partnership between 4 organizations, maybe now 5, who are doing things together that we wouldn't be able to do by ourselves. So the doctors and nurses come from ICHA. The health navigators, social care workers, and our peer workers come from a community-based healthcare organization called Kensington Health, where Kensington Hospice is based out of. Our home care workers come from government-funded home care kind of part of our universal healthcare system. So home care in Ontario is called Ontario Health at Home. That's like the brand name, but it's publicly funded home care. And then we recently have a growth partnership opportunity where we're getting some of our roles funded through St. Michael's Hospital, which is an inner city hospital in Toronto. So, the reality is that we wouldn't be able to deliver Peach if we were one entity. We're able to deliver the full spectrum of what Peach has to offer because we all work together. And that's not common in healthcare, that organizations kind of like come together and drop their safeguards and guardrails and like share data, share staff. Like even though I may not work at all these organizations, I have a dotted line reporting structure with some of the staff in the other organizations, and that took a lot of like organizational leadership, things I don't know too much about, and people smarter than me that figured it out and helped us out with to kind of create those connections. But yeah, it's a great question. It's super fair. I know our system is structured totally different than yours, but there might be some parallels as well. Great, thanks. Awesome. Sam.
Hi, thank you so
Hey.
much. I really have loved everything that you've talked about so far. I have kind of a pragmatic question that probably doesn't have a clear-cut answer, but I'm just wondering if you have any effective strategies for identifying palliative care providers who might treat people who use drugs well. Because from what I can see, it seems like a pretty obtuse uh, structure where we're at. And so any sort of ideas that you have would be really helpful.
Yeah, thank you so much. Really important as we are developing models of care and developing public health approaches to equity-oriented palliative care. We need to start cataloging who's doing what, who's not down to do this, who might be down, and who is, right? Okay, from my perspective, I would start with the National Healthcare for the Homeless Council, NHCHC, which is based in your great state, which is so ironic and cool. And so it just so happens that we've just finished a 3-year journey with NHCHC, working with them to develop a best practices resource that we launched last year in Baltimore at the annual National Healthcare for the Homeless Council conference. Understandingly, that like I know you're talking about substance use specifically, but there is overlap. And actually, what's been so cool is that the National Institute for Medical Respite Care, which is an offshoot of NHCHC, is cataloging all the providers who are doing equity-oriented palliative care, particularly for people who are unhoused, but people who use drugs. And harm reduction has been, obviously, as it should be, a massive thread throughout that. So actually, afterwards, Caitlin Sinovic at NHCHC has been like my contact. She's the executive director of the National Institute for Medical Respite, and she personally is cataloging this like with her team. And I think you should, if you haven't already, reach out to NHCHC, and I can do an introduction with Caitlin if that's helpful. And I'm actually blown away at like how many people are like doing this, trying to do this, trying to get some semblance of this. It's really, really inspiring. On the Canadian side, like there's about 23 of us now because of this Health Canada project. And there's a website called Healthcare Excellence Canada. I can send the link for the IEPC initiative, and there's a catalog of all the programs and what they're up to and where they're at, and everyone like supports harm reduction to some degree. It's like kind of like a requirement for the program. So yeah, that'll get you started, I hope, Sam. But like you can always reach out, and we could chat more about who's doing what as well.
Thanks so much.
Thank you. Great point. Great question. And that's so cool. You found Dr. Jill. Yeah, that's Dr. Jill. She's super cool.
And then you have one more question in the Menti, and then I think we're going to move on, unless other people have questions, but let's do this one first.
Great. Back to story. How do you share stories with the audience that need to hear them most? What does this practically look like? Yeah, it's such a great point. I think the first of all, when it comes to storytelling, you need a strategy, right? You need to kind of have a sense of what are you trying to achieve? Are you trying to achieve a story for the purposes of expanding spread and scale to influence policymakers and funders? Are you trying to bring the Canadian public on side as part of a larger movement to create a more compassionate community when it comes to an often stigmatized population? Or are you trying to do something else, more specific? I think at the outset that needs to be kind of discussed. I'll give you a few examples of stories that like we did. I'll reflect on the very first story we did in 2014 with the Canadian Press, which is our biggest media outlet that does Canadian-wide and international stories that can get dropped in different media outlets. We just really wanted to tell people that the Peach program existed and was there. And we told the story of Dan Thibodeau, a younger man who fell into a life of drugs and had been really separated from his children and was diagnosed with stage 4 cancer, and the resilience and strength that he showed in getting housing and dying within that housing after years on the street. That story went viral and like really put Peach on the map in terms of being an entity. I'll fast forward to the COVID-19 pandemic when we just were inundated. Our referral rates went up 4 times during the pandemic, as I'm sure many of yours did. And, there's just a huge, great need. And we needed more resources and more funding. And so we partnered with a media outlet called Global News here in Canada that has national reach. And they did a 3-part story on how we are just overwhelmed. And that was the domain of that story. And that led to, get this, philanthropic funding. We actually got donors reaching out, and we actually got a huge grant that was really, really huge and monumental for health navigation. And we actually had our inaugural health navigator funded through that philanthropic grant. We were able to show that palliative care health navigation makes a huge difference. And then later, Kensington Health picked up that funding in a sustainable way because we had the test pilot case. That was super cool. And then we just have times where we have clients who just like want their story told, and that is part of the healing as they go through their palliative care journeys. And so, yeah, we will like pitch their story out to people. So we've done that with CBC Radio's White Coat Black Art, a radio show that talks about like the art of healthcare. And we've had clients go on the show and tell their story. We've had, I remember Pandora, a young woman who was dealing with infectious endocarditis and was a person who used drugs who just wanted her story told before she died. And she got a documentary on CBC's The National, a 9-minute documentary, which is super cool. And like, sadly, she died amidst the filming, but it was like so sad. But at the same time, it was the greatest memorial and memorialization of her life that her last wish was to be filmed. So that I think is super powerful in terms of storytelling. I think in this era where like traditional media is like whatever, it's just a side thing nowadays. Like the power is in our hands, right? Where whether it's like mediums like Instagram or TikTok, or if it's about getting onto written platforms like Threads or X. I don't know about X anymore, but Blue Sky, or whatever it is. Like we can go out and engage in that storytelling as well. I still am a fan of call me old school of just writing an old fashioned op-ed and dropping it in a newspaper and like making a statement. I tend to do that when I go to a city and I speak. I like to like drop an op-ed in that city's newspaper to say these are the issues with a local colleague who's doing great work to like prop up their work as well. So there's that as well. So yeah, communications amidst this hyper-polarized environment is its own thing. It's super challenging, and it needs a strategy. That the problem is like we're often functioning in programs that are hanging by a thread with in terms of funding. Like who has funding for a PR and comm strategy? But sometimes a partnership, a collaborator you can leverage their newsroom. Can we borrow like a point 0.4 FTE from some of your comms team to work with us for like a month or 3 to develop a strategy? Volunteering, maybe the philanthropy is actually PR talent. Maybe that's what philanthropy can drive. We got to be creative, but yeah, we need a strategy for sure. Great question. Thank you.
Cool. Thank you. We're gonna move on. We'll stop the recording right now. Like I said, this will not be posted publicly.